friends. Good evening, my teachers and dear students. So, the topic for today is flexible ureterorenoscopy, or in other words, it is called as RIRS. And RIRS and ureterorenoscopy, as the name says, RIRS stands for retrograde intrarenal surgery. So it makes use of a flexible scope and replaces the semi-rigid scope that is normally used in URS. So I'm Dr. Mrinal Pahwa. I'm working as a urologist in Gangaram Hospital, and I welcome you all on behalf of Conceptual Surgery. So I'll be starting my talk with a brief overview of URS and then take it forward to RIRS, because RIRS in basic essence is the next evolution of URS. So taking a cue from URS, we'll be proceeding towards RIRS. So the whole point has been that of surgery is to develop new minimal invasive techniques for dealing with the thank you. So the whole point of surgical practice has been to develop minimally invasive techniques which are beneficial to the patient, and a lot can be done through a small incision, basically, or no incision. So that's the whole essence of surgical practice world over, and we have moved over to endoscopic surgery, which is the purely minimally invasive technique. It doesn't require any incisions or anything. So it's in purity genuine minimal invasive technique when we talk about endoscopic surgery. And the development of small caliber flexible instruments has made it possible that endoscopic surgery has seen the light of the day, especially in urology, to treat not just stones, but conditions like tumors or any AVMs or any SOLs, basically. So it has served both a diagnostic and a therapeutic role. So why there's a rising trend? Why we aim for minimal invasive methods? Because stating the obvious, it's shorter hospital stay, lower cost, improved cosmesis, and early return to work. So which is something that in today's world we look forward to. Everyone wants to get back to their routine as early as possible, and that is what URS and RIRS and other endoscopic techniques strive for. So time immemorial, we have been using ESWL, which is I would say even more minimally invasive technique than URS, but we have achieved not very optimum results with ESWL in all the cases. So hence the need for URS. So just tracing the history, it all started with Hugh Henry Young when he used a 12-French cystoscopy, and it was used in a patient of PUB, and he directly entered a ureter thinking that this is a continuation of the bladder. And ironically, he was meant to do cystoscopy, but in fact, he was doing a ureteroscopy. With 1964, Marshall developed the first flexible ureterorenoscope, and it was further elaborated by Fuchs and Fuchs, and later by Goodwin and Lyon. The Fuchs and Fuchs reported their first series of successful flexible URS, and the contemporary RIRS technique that we use using flexible scope and laser was used by Grasso and Shelik in 1998 for the first time. So this is a brief overview of how the ureteroscope has evolved. So it all started with rigid ureteroscope, which we don't use now. They use the rod length system, and they were very big in size. Their diameter of 12 to 13.5 inch, and they required dilatation in almost all the cases before we could use them for ureteroscopy. And it gave way to semi-rigid ureteroscopes. So semi-rigid because these ureteroscopes can bend a little bit, not although they appear very stiff, but they have it in them the inherent innate property that the shaft can bend at places just to maneuver all the way in the tortuous ureters. So that's why they are known as semi-rigid ureteroscopes, and they use fiber optic illumination. And later, flexible URS and the future trend that we can look forward is robotic URS and virtual URS. So what I've just told you about, these are rigid scopes, the flexible ones and the semi-rigid ones, which is conventionally used for RIRS. So how do we proceed? We review the patient's radiology. So like in all other surgeries, the principles remain the same. The first and foremost, I think, for any surgery is the selection of the case. If you got your patient right, then the surgery should go on perfectly fine. But if the selection is not optimal, then you can expect anything extraordinary. But the foremost principle is to select your case well, because in endourology, in urology, a same thing can be dealt by 3-4 methods. So there are 100 ways to skin a cat when it comes to urolithasis, and it all depends on how competent and how comfortable you are using either of the techniques. So choosing the right patient is foremost, and it all depends on stone, its size, location, density, where it is located, how big it is, and how dense it is, whether it is amenable to laser lithotripsy or not, and will it require more time, stage procedure, stage settings, all those things. So pre-operative preparation, like in any other, we need to rule out UTI, and we preferably need to stop anticoagulants. But in presence of a single anti-platelet agent like aspirin, we can still perform RIRS.